So once the blood is transported from blood bank and checked into the transfusion medicine unit, it is ready to be cross-matched for patients on the ward. Next slide, please. So let's look at some of the policies that govern transfusion medicine, beginning with sample requirements. So a common cause of transfusion error is a submission of an incorrectly labeled sample to the blood bank or transfusion medicine. It is therefore mandatory. I don't like necessarily using that word, but it would be helpful that the following steps be rigorously followed. So what we would ask of you as a physician is that when you draw a specimen, the first thing that we would like for you to do is to just make sure to verify the patient identification using the full name and medical record number as the two identifiers or unique identifiers for that patient. We require you to use a lavender top tube, which should be filled at there's a black mark on that tube. So it should be filled at that level, and the tube should be inverted at least 4 to 8 times so that no clotting may occur in that specimen. May I have the next slide, please? So sample requirements. For any request to be honored by the transfusion medicine, the requisition must have the patient's full name and last name, the medical record number, the date of birth, and the date that the sample was drawn. The signature of the physician or the person who may have drawn the blood should also be written clearly on the tube. So some of the type of samples that we're getting in the transfusion medicine area is that we are seeing samples that only have the patient name and the medical record number, and that is it. Sample requirements require that all fields that are on the sample tube are filled out completely. We're asking if you can assist us with that. Even though in our system, we use only 2 unique identifiers, the name of the patient, as well as the medical record number. By no means I am suggesting that you do not fill out the fields on the tube. It is very helpful in helping us to differentiate further when we have patients that have the same name, different birthdays. So we look for other things that can distinguish patients and to help us identify which patient may be the correct one. If we are in doubt, may I have the next slide, please? So basically, the slide is reiterating what I've just said. Making sure that your sample has 2 identifiers on it, but again, still filling out all of the fields on the tubes, that you fill the sample up to the black line, which is 3 mLs of blood using the lavender tube. And definitely, we would like for you to ensure that you accompany a request form with the sample. So what we've also been seeing is that once a sample has been requested in ICE, we do not see a request form accompanying that sample. So what I'm asking you to understand is that the software that we use for the blood bank is not integrated with ICE or SunQuest. So if you bring a sample down that just has a label, the unique identifier of that sample for us to have traceability in the laboratory and throughout the system will not be possible if we use the SunQuest labels. So you will need to send a request form for blood, even though you may have placed it in the SunQuest system. So let's look at the first sample and the second sample requirements that we ask for physicians to provide for patients. And what does this mean? So we call this the two-sample rule. So the most prevalent transfusion errors is the erroneous transfusion of ABO incompatible blood. And when it occurs, almost always reflects a preventable breakdown in transfusion protocol and standard operating procedures, such as the improper identification of pre-transfusion blood samples. Now, transfusion medicine must ensure that there are two distinct samples from a patient. The same blood group must be present in both samples. If we have seen the patient before, we would have a history or historic blood group registered on our software. Then only one group and cross-match sample is required. However, if the patient has no previous records in our blood bank software, then you must repeat the group and save and resave and cross-match with a second sample. We have seen an unacceptable number of wrong blood in tube cases among patients where it can be detected due to having a historical group on record. The two samples must come from separate venipuncture events and ideally should be carried out by two different staff members. So this is a policy that we have tried to implement because of what we have seen, the discrepancies of samples with persons that have come in for the first time. We don't know what their blood group is. And later on, we find out that maybe it was the wrong sample that came to us. So we implemented this policy where each patient whose history we do not have in our system, we will require you to do a second draw in order for confirmation of the blood bank of the ABO to occur. Can I have the next slide, please? Alrighty, so this just basically continues on with some of the things that we have seen incorrect or inaccurate forms. What we do as a result of that is we discard the forms and we try to see if we can reach out to the physician to advise to submit another sample. Can I have the next slide, please? So let's look at our policy on sample rejection. So one of the quality assurance indicators implemented by transfusion medicine is specimen rejection, where we look at the number of specimens that are rejected due to error on requisition forms or specimens. Next slide. So these are some of the things that we've seen. Discrepancies with patient identification, incomplete labeling. Complete labeling is required on all specimens received, and it must match that in the test requisition form. Specimens without full names, last names, date of birth, specimens with double labels. If the underlying label has the same name and the number as the overlying one, the specimen may be accepted. So what we've seen is that for the past, in 2022, we noticed that we had about 4,000 samples that we received for cross-matching in the transfusion medicine department. We found that 118 of them gave some discrepancy. The majority of that 118, which was about 68 of those samples, was due to mislabeling. Either the sample and the requisition, in most cases, did not agree, or the information on the sample and the requisition did not agree. Okay, can you move down to slide number 16, please? So let's look at our policies on blood request forms. Next slide. So we know that donor red cells are tested against the patient's plasma for compatibility. So once compatible, this unit may be reserved for patients. Note that one unit may be reserved for multiple patients. So reservations are based on inventory. Next slide. When you are requesting or making a request for blood, we ask you to indicate the type of product that you would like, whether it's red packed cells, platelets, or FFP, and the quantity that you would prefer for the patient. Sometimes we get forms that does not clearly indicate what a patient would want. And sometimes we would probably make a guess of that you would want 2 packed cells. Next slide. So again, I've spoken to this, that we would like for you to put the number of units that is requested, the date on the form that you require, not ASAP or as soon as possible, but we'd like some indication as to when you would need the unit. And of course, the ward, we're asking for you to place that on the form as well. That is the only way that we can contact you if we have a problem with the sample. So this slide is just another reiteration of what we are requiring with our requisition form and all of the necessary information. We would like for you to also put on the form indication for transfusion, whether it's a severe anemia or some other condition. And if you can give history of a previous transfusion, that would be helpful. So again, reiteration that we require you to fill the forms out correctly, please, so that it can assist us to provide the correct units that you would like to in a timely manner based on the inventory available. So let's look at our blood issue policy and procedures. According to our standards, we know that physicians, nurses, interns, our trained clinical nurses, our PCTs, they can all collect and sign for blood products. Physicians must order for the client to receive a transfusion. Consent forms must be verified prior to obtaining the unit. Transfusion must be initiated by a registered nurse or a physician. It can be initiated by nurses in training in the presence and guidance of a registered nurse. This form here is what we require to be presented to our window when you would like to request, either to find out whether or not units are available for a patient, or whether or not you are here to pick up units for a patient. We ask that you fill it out properly as well. So the release of blood products, all our units are labeled. Only 1 unit of packed cells are issued at one time to the ward. It must be cross-checked at the distribution window. We want to make sure that there's a positive ID of the recipient, plus the blood group. We want to make sure that the unit ID and the blood group is correct, that the donor blood group is the same as the recipient blood group. And if we have a donor blood group that is not the same as the recipient group, then a physician must sign for the blood component. So below is the form that we usually release and that would accompany the blood units that we give out at the issuing window. Could you just go back to that form for 1 second, please? So there are parts of the form that we require signatures from either the doctors or the nurses in order to indicate that the transfusion has occurred, as well as we are requiring for the time to be put on the form when the transfusion had begun and when the transfusion ended, and whether or not there were any transfusion reactions. Those should be indicated on the same form. There are areas here that you need to indicate. Also, signatures should be placed in the given areas to show who the responsible person would have been for transfusing the units to the patient. Thank you. We can go into the next slide, please. So we want to stress that it's very important that blood should be picked up only when the transfusion will be started immediately. So blood should be collected only if it will be used within 30 minutes of issue. Once it leaves here, it should not be placed in an unmonitored refrigerator. It should not be placed on the clerical desk of the ward. It should be on its way to the ward in preparation to be transfused at least within 30 minutes of it leaving here at the transfusion medicine unit. What we plan to do probably the next month or so, you will notice that we will implement where blood components now must be transported in coolers. You will be provided coolers, and units will not be allowed to be collected unless a cooler is available, or you bring one that the blood can be transported in. Can I have the next slide, please? So this is basically a protocol of what should go on the wards in order for verification of blood transfusion and verification of patients prior to the transfusion being done. So the patient's first and last name, medical record on the transfusion confirmation form, and form attached to the product must correspond to the information on the patient. The blood type and donor unit number on the cross-match slip should correspond to the blood type and the unit number on the blood bag. The above identity checks must be documented in the appropriate place on the form. So we have several verifications going on just to ensure patient safety and that there is no mistransfusion or transfusion errors between the transfusion unit and the ward. The document that is being shown now is just an excerpt of a section that is on the transfusion form that should be filled out that will indicate that all of the checks were made. Next slide. So this is our blood return policy. Any blood that is returned from the operating room will be returned to available status immediately. Only antigen negative units will be put on hold for the patient. Blood returned from any other ward except or are acceptable for reissue only if returned within 30 minutes. They must not be warmed, their ports intact, And if these conditions are not met, it will have to be discarded. Transfusion reports form will be printed in duplicate from our eDelphin system is the software that we use. And once the unit is transfused, one copy is to be kept in the client's notes and the other sent with the product back to the department. We also ask that you detach the needle from the transfusion bags when you return them. Next slide, please. And I think I spoke to this earlier, that the units are not to be placed in any unmonitored refrigerators that may be on the ward. Bearing in mind that RBC or packed cells should be stored at 2 to 8 degrees, and platelets at room temperature, as well as the FFP. Once they are poured out, they should be given immediately. I think you have maybe about an hour or 24 hours before they are expired once we have thawed them, but they should be given immediately. Next slide. So let's talk a little bit about transfusion reactions. So we know that these are undesirable responses or effects in a patient that is temporarily associated with the administration of blood or blood components. Now, there are two types of transfusion reactions. We have the acute transfusion reactions, where we would see symptoms appear within minutes to up to 24 hours. We also have a second transfusion reaction in a delayed reaction where symptoms appear after 24 hours and up to 30 days and is caused by secondary immune response. Next slide. So when this occurs, the patient should be evaluated by the physician. If a transfusion-related reaction has occurred, we are requiring that you submit a post-reaction blood sample in a purple top tube. Samples must be taken from the opposite arm of transfusion. And we also require a first voided post-reaction urine sample. The form accompanying each sample should indicate post-transfusion reaction. Next slide. So these are just some of the acute reactions, signs, and symptoms that you may see in patients: fevers, trills, sweating. So the transfusion medicine department should be notified immediately. And we just said that we should have a post sample from the opposite arm in two lavender top tubes. And of course, you would follow the same labeling procedure that we spoke about earlier. And both samples should be sent in separate biohazard bags. Okay. So no additional transfusions may be given until the workup is complete and the nature of the problem is known. Here in transfusion medicine, the technologists, we will review all the clerical aspects of the transfusion, including the patient's record, a pre-transfusion cross-match, issuing requests or any discrepancies, visual inspection of the pre- and post-transfusion samples, plasma for hemoglobinuria, we repeat the ABO grouping, etc. The director will communicate the aforementioned results to the clinical staff. Delayed reactions, signs and symptoms. Patients may now show a new positive antiglobulin test or antibody screen or both, with fever, jaundice, joint pain, abdominal pain, purpura, and bleeding. So physicians must telephone the supervisor or director with a summary of his or her findings, request investigation, and then ensure samples are sent correctly labeled in a lavender tube, as we said earlier. So this is basically a summary of, I guess, our blood bank workflow. So for the donor, we do our ABO grouping. If it is a RH negative, we do a week D. We also do antibody screening along with the infectious disease screening. The donor is reconfirmed, the ABO is reconfirmed, and then the unit is sent over to transfusion medicine service. We then would receive a sample from the physician or the ward from a patient. We do an antibody ID if necessary, but we do antibody screening. That is after we do the antibody screening and we would find the antibody positive. Then we would do antibody identification. We ensure, or we look at the history of the patient to ensure that patients do not have any previous antibodies that were identified. And we try to give antigen-specific, phenotypic-specific red blood cells. We then issue the specific or selective components that is ordered by the doctor once we have done the compatibility testing. And we label the units with the appropriate labels for the patients, and we issue the product. I would like to thank Dr. Wallace Bain again for allowing us to share this information with our physicians. And I hope that it has been informative and that it will help us to mitigate some of the pain points that we do experience here in the laboratory, but also find some resolutions on how to build a better relationships and to improve patient safety here at the Princess Margaret Hospital. Thank you once again. Are there any questions?
Thank you. Thank you so much, Ms. Bullard. This has been very informative.
Yeah.
There are a lot of things that we may often take for granted when it comes to requesting blood and how we get it. And also, there we go, specifically regarding blood transfusion reactions. So a lot of useful information, and I hope that we all receive that information so we can have a smooth process in our blood request process. Okay, so we have a raised hand. Dr. Chisholm, you can go ahead.
Hi, good morning. Thank you for an excellent presentation. My question is for Pete, do you need the 2 samples as you're now requiring just because of the risk of excessive blood draw? That's the first question. And the second question is, do you still require a maternal sample for the neonates, and up to what age do you require that?
Okay, so the neonates, okay, so I didn't catch your first question, but I'm going to start with your second question. We still do require the mom sample for the neonates, and that is for the newborns. So once we have gotten that sample and done our first cross match, we usually would try to reserve a unit for that particular baby. and not to use any other units that we have there until that unit is completed. And once
Okay.
we have, yes, so we try to use, if we have a unit of pack cells, 250 pack cells, we would try to split that unit just for that particular baby that needs that unit, so that we do not require so much blood from the baby to do the cross matching. So we would just aliquot and release that unit. And then we would only require another sample once that unit has been used.
Okay. And just to
So you could,
clarify the first question,
yes,
you had mentioned that you now require 2 samples for blood cross matching. I'm just
yes,
asking that for pediatrics as well.
yes, we do require
Small babies. Uh-huh.
yes, for our
Okay.
newborns. We do want to ensure that the blood group is actually what that first, if we do not have a history, we do ask for it for all patients.
Okay. Thank you.
Okay, you're welcome.
Thank you for that, Dr. Chisholm. Dr. Lockhart says, good morning. Thank you for this information. What is the minimum amount of blood you need from the pediatric population?
Okay, so we have feed tubes, the very small ones. We request that you have at least 1 cc in those feed tubes in order for us to perform either a blood grouping DCT or cross-matching. Okay. Other than that, if it's in it becomes more challenging if we have the 3 ml or the 5 ml lavender top tubes, because those tubes require a specific ratio of blood to the anticoagulant in that tube, and it makes it a little bit more difficult to even retrieve serum if we need it off of that tube. So if you have pediatric patients, we do advise that you use the small pediatric tubes where we can use those better and manipulate those better to get what we would need to do the testing. And we don't have to send anybody pressure up when we call to say we need a new sample. We don't want to do
Okay.
that.
Thank you. Dr. Conliffe says, concise and informative. Thank you, Ms. Bullard. Dr. Hannah
Thank
says,
you.
she's asking, is antibody testing routinely carried out on O negative patients? And can you advise on the criteria for antibody testing? As your slide stated, it is done if necessary.
Okay, so the antibody, I think that particular slide spoke about antibody identification. So once you send a sample down for group and cross match, we screen all patients for antibodies. If that patient panel or screen is positive, then we move to identify that specific antibody that the patient has. So maybe the patient may be identified with an anti-big E or anti-big C. What we plan to do, or what we try to do, is that we phenotype the donor cells for those specific antigens to ensure that we do not have a transfusion reaction by that patient, experienced by that patient, due to the unit that we may have issued. So whenever we identify an antibody that a patient is circulating antibody, we would always phenotype each unit, whether it's Duffy, Kell, whatever it is, we would phenotype those units to ensure that the antigen is not on the donor cells. So if the antibody that statement really speaks to the identification of the antibody if we screen and find that one is present.
Okay, thank you. Thank you for that. And she says, thank you much. Are there any
You're welcome.
other questions for Ms. Bullard? Any questions or any comments for Ms. Bullard?
I would like to ask, I know that we have a lot of protocols in place in transfusion medicine, and whether or not there are, I know this is one way that we're trying to help to bring understanding and to expectations. But is there any other way that we can make it, I don't know if I can use the word easier or more friendly in terms of you I guess being able to institute some of this on the ward? It's not something that it can fall away easily because we're trying to follow best practices. And sometimes it is tedious to do that. But are there any challenges that you feel that you should share that we may understand so that, we can better maybe deal with situations that you may encounter?
Okay, that's a question to you, the physician body. Any immediate thoughts? While you think for a brief moment, Rosemary Josie is commending you, Ms. Bullard, by saying, excellent presentation.
Thank you. It's been a pleasure. I hope we can have more discussions as this one.
Absolutely. So I think my physician colleagues are eagerly thinking away as to ways in which there can be, a more easier or smoother transition. They're thinking, and I'm sure they will get back to you. They can reach you at Transfusion Medicine or Blood Bank. You just go down there, ask for Ms. Bullard, and you can find her. If you have any thoughts and you're not able to reach Ms. Bullard, you can reach me, and I will be more than happy to get that over to Ms. Bullard for you. Because at the end of the day, we want to have a safe, smooth process for our patients. So as I do not see any additional hands at this
Dr.
time.
Wallace,
Oh, hi.
apologies. I was looking for where the raise the hand thing is on my phone.
I just was going to mention Dr. Okay, go ahead, Doctor.
Dr. Lockhart.
I apologize.
Okay.
So one of the things that concerns me is, in particular for pediatrics, because I feel like we always get left out in terms of the whole process. So in particular for getting results, having to call the blood bank is very difficult. I know you guys are busy. I'm trying to figure out a different way that we can actually get our results rather than having to pick up the phone and call. Sometimes we have to call multiple times, come back at different times during the day. Then the phone systems weren't working for a long time and nobody would pick up the cell phone. And so that has posed a real great difficulty. And yes, my blood pressure has been very high in the last couple of months. And then, of course, because you guys are busy, the reception that you get when somebody does pick up the phone is like you're bothering them. And I know I'm bothering you, but I would prefer to do it a different way as well. So if you could just comment on that.
I do appreciate you expressing that. I'm fairly new in this chair, and I will try my best to address it. Now, when it comes to the blood results. I think I started to talk about the integration of our system. We are on a different system than SunQuest or ICE. Our system is a strict blood bank system, and so it doesn't allow for results to just integrate and populate over into ICE. We have tried and been asking for that to occur for many years before I have been here, I've been told. And so that is something that we are going to have to work on. The reception of realizing that we are here for each other and that we should treat each other as we would like to be treated are some principles that we don't carry on all the time when we are in a stressful environment. It is something that I guess that I will need to speak to with my staff, even though at some points I'm told that they get the same sort of, I guess, pushback on the other side, I guess, when there's some urgency on your side as well. So I think that if we continue talking, trying to understand, everybody's working 24 hours, 16 hours, so forth. So I will not like to use that as an excuse. But I can say that I will do my best to speak with the staff, see how more cordial we can be, and how we can look at providing the results otherwise. Now that will have to be escalated to management position to make that type of decision in terms of those results getting out to you, or you having to call and the phone is ringing. But we do have some challenges internally that I'm hoping that we can address quickly.
Okay, thank you. Dr. Thompson, you had a question?
Yes, good morning, and thanks for the presentation. What I want to find out, I know you talk about the blood being, it should be used within half an hour. But I think the thinking is the blood has to be warmed up so warm before it's given. Because I know on the wards, they're sitting there because the nurses say they're waiting, or persons are saying they're waiting for the blood to warm up before they start the transfusion. So is there a time, like the half an hour includes that time to warm up? Why it seemed like they're waiting for this blood to warm up before they can administer it? Maybe you can speak to that for me, please. Thank you.
Okay, so what I guess what we have noticed is exactly what you said, that persons are waiting for the blood to warm up, and sometimes they remain there for an hour or two. It is documented, once the blood has reached a particular temperature, that the risk of either bacterial contamination or other things can occur, or the efficacy of red blood cells may not be the same. I don't know if there's a lot of literature out there regarding the effect of actually transfusing the blood half an hour afterwards and there being reactions to such an extent to the patient. We do know that there may be more concern for the blood not being, I guess, at the right temperature or being at a higher temperature than it should be, and maybe causing other concerns like bacterial contamination, or whether or not the red cells are actually more effective. So I think it's a weighing of those things in terms of whether or not, the half-hour period and then the blood is being given over a certain period of time. So I'm not sure if that would have answered your question, but I know that we do have that practice where they're waiting for the blood to warm up on the ward, and we are not advising mechanical warmers to do so because most of the times the blood is at such an extreme temperature, it's unusable. So the hard and fast of what we understand is that within half an hour of receiving that blood, it should be transfused.
Okay, thank you. And our last question in the chat is, when will the coolers be available for blood transport?
Okay, so we have we have ordered them. We should have gotten them in-house this week. So next week, if they are in-house, we are going to get them labeled. And we want to put each ward name on them. And once we've done that, we may have some type of short presentation about expectation and so forth. But I would say in the month of May, it should not go past then with trying to get it organized. We ordered about 25 coolers. And so each ward should be able to get a cooler and be able to keep that cooler for when they would need to come down and pick up a unit of blood or some blood component. So I would say by May, mid-May, we should be able to execute and implement that.
Okay. All right. Thank you. Thank you very much. Looking forward to moving on to bigger and better things. Thank you again, Ms. Bullard, for taking the time to give us this presentation. It was a wonderful presentation, packed with lots of information, useful information that can help and augment the practice of transfusion medicine. Now, I want to remind everyone to kindly fill out the feedback. It is inside the chat. Please click on it and fill it out. It takes just a few minutes. We want to hear from you. And by way of announcements, I also want to remind everyone that we have another exciting CME that is coming up next month in May, second Wednesday. Look out for the flyer and plan to attend. And once again, just letting you all know that after attending this CME, you have just leveled up in your knowledge. Thank you and have a wonderful day.
Thank you.
Good day, Dr. Wallace. Sorry, I put one last question in the chat, which I'm not sure if you saw. My apologies, Dr. Hannah here. I was wondering if there was a bank registry associated with PMH. We constantly see persons asking for blood donations, etc. So I was wondering if there was a registry. So if a particular blood type is low, you have a group of people that you can call in to donate, etc. I'm not sure if Ms. Bullitt can answer that question. Thanks.
We do have an electronic system where we can track when our donors came in, when their donation times are up. We do have that. Right now, we are at a really critical level for Rh negative units. And we have several of the patients here. We have reached out to that registry of donors. I guess the only other thing now is for me to go before the television and to appeal to the general public to come in and to on behalf of our patients. But we do have a register or a form, a software where we can pull those patients or donors and call them when we need them.
Since you mentioned that, I would also like to take this opportunity to put a plug in there. And speaking about that, we at the CME department, we are going to be hosting our very first, the inaugural community medical education. And we're excited about it. You may have seen the flyers. We were supposed to have it back in March, but unfortunately, the weather just did not allow us to do that. So we're planning on hosting that event next month, which is quickly approaching May 25th. So look out for the new flyer regarding that. And by doing that, we are hoping to get out there and to sensitize the community about the entire process that is involved with this, because there are a lot of miscommunication out there. And if you talk to members in the community, the process, they're just not having it. The conversation isn't going beyond, will you? It just gets cut short. And there are a lot of misconception. And Ms. Bullard will be a part of that panel helping us to get that community education out there. Because if we can sensitize our community members, then hopefully we want to get to the point where we don't have to get out there and beg for blood, but people would have that new appreciation and would voluntarily come and donate blood, which is what we want. That is what we are striving for. So very, very super excited about that event. And I hope that you spread it among your church families, your home, your other social groups. When you see the flyer come out, before the flyer even comes out, you now know that the event is coming. So start spreading the word. We want you to show up as well and lend your support. And we're hoping to have a wonderful event. We're hoping to have a lot of people. And at the next opportunity, we're hoping to hear that the blood bank overrunneth with people waiting to donate. So look forward to that event, and I look forward to seeing all of you to that event. We have some more. Good morning, very informative presentation, excellent presentation, and thanks very much for the answers. Okay, I think we have, yes, I have covered everything inside the chat. I see no hands, so we're good to go to start our Friday morning. Have a great day and a lovely weekend.